Dr. Morganstein is obviously with our military. He's up at USIS, and he's with the Center for the Study of Traumatic Stress. I've been doing this stuff for about 40 or 50 years, and the most pervasive problem, no matter what the disaster, what the event, what the culture, is mental health and the associated morbidity that goes along with it. And it is not just obviously during the acute phase, it is persistent for long periods of time. And as a result of that, we really wanted to get a mental health perspective from someone who really focuses on this area. And Dr. Morganstein was gracious enough to give us his viewpoints, and I will now turn it over to him. Thank you.
Great, thanks. I'll go ahead and share a screen here with you. And thank you for the excellent introduction there. A nice segue into our talk today. Can you hear me?
Can hear you, yes.
Good, good, thank you. Well, it's good to be with you today. When we focus on disasters and mental health, I think we often think a lot about treatment of psychological disorders for individuals, which is certainly an important aspect of restoring health in disasters. But as we consider climate-related disasters and other disasters more broadly, I'd also like us to think about communities and prevention in our efforts to protect and foster health. These are my thoughts and ideas, and I have no disclosures or conflicts of interest to report. So in the brief time we have today, I'll talk with you about the mental health effects of disasters on individuals and communities, aspects of risk and vulnerability to these types of events, and a framework for interventions to support and protect health of our communities. And obviously, a lot could be said about these, so we're going to kind of crest the wave tops on these things in the hopes that they spark some interest and thoughts and leave a few, hopefully, action items for you to think about and resources that might be useful in the work that you do. Much of what we know, in fact, about the impact of trauma comes from our study of disasters, including those that are considered human-generated, as well as climate-related disasters, which are certainly influenced, of course, by human behaviors and systems. And in fact, many climate-related and other ecological types of disasters involve naturally occurring events that are exacerbated by human behaviors. Hurricane Katrina began with storms, but then ended with a damaged levee that could have protected thousands of people. And in Fukushima in Japan, for instance, an earthquake led to a tsunami that damaged nuclear reactors, displacing 160,000 people. So in this way, and certainly as our most recent and persistent disaster of COVID-19 has reminded us, disasters aren't simply single events. And around the world, disasters are becoming more frequent and more severe. 9 of the 10 costliest hurricanes in US history occurred in the past 2 decades, and 5 of them were in the past 10 years. A greater number and severity of disasters leads to a greater burden of mental health for our communities. And it's difficult to talk about disasters right now in December of 2021 without considering the impact of the global COVID-19 pandemic. Nations around the world certainly are experiencing not just the pandemic, but really the collision of multiple disasters, many of which are challenging our society's values. Disasters in general open the fault lines within communities, further exposing issues around race and religion and socioeconomics and health equity. So it's useful to start by reviewing some of the psychological and behavioral effects of disasters on individuals and communities. The 2016 report on the impacts of climate change on human health was the first federal document that focused exclusively on health-related effects of climate change. Our chapter on mental health and well-being summarized what was known about the mental health effects of a changing global climate, and much of that knowledge has emerged from the study of disasters. Disasters produce significant mental health burden for communities, as James was just alluding to. And historically, in nearly all disasters, The psychological and behavioral impacts are experienced by more people over a greater geography across a much longer period of time than all other medical effects combined. Certainly, the medical effects of something like the COVID-19 pandemic are wide-ranging, and the number of people who've become ill or died is extraordinary. But far more people will ultimately experience adverse mental health effects of the pandemic. And if history is any predictor, we should expect a significant tail of mental health that needs resourcing and planning now. Much of disaster studies are about PTSD and other psychological disorders, and we have good treatments for PTSD and these disorders. These are perhaps what's best known about disasters. So I'm not going to talk about that today. There are other types of outcomes of concern that are less thought about and less talked about, and I'll highlight those. So before psychological disorders occur, and certainly with greater frequency, people experience distress reactions and they engage in health risk behaviors. Insomnia, a decreased sense of safety, substance use, and family conflict. These are all common after disasters. For instance, the most common complaint in New York City emergency departments immediately after 9/11 was for insomnia. We might also consider the use of increasing alcohol by a community, regardless of whether or not somebody actually has alcohol use disorder. The increased use of alcohol itself is associated with work errors and accidents, presenteeism in the workplace, family conflict, and violence. Distress and health risk adversely impact well-being, and they contribute significantly to public mental health burden during disasters. And it's also good to remember that the vast majority of people, including those who experience difficulties along the way, will ultimately do well. Many people will even experience an increased perception of their ability to manage future stressors. And as we're all still living through the disaster of COVID-19, these are particularly important messages for us to share with our friends and our families, our coworkers, our patients, and even to remind ourselves. Disasters also are not simply local events. Their impact is felt broadly throughout a society, well beyond the geographic boundaries of the event itself. Hurricane Katrina was one of the costliest US disasters in history, which claimed nearly 2,000 lives. But it also displaced approximately 1.5 million people who lost their homes and neighborhoods, their existing social, economic, and healthcare supports, and whose burden of community distress was transmitted throughout the country when they relocated. The psychological and behavioral effects of disasters unfold over time. During the honeymoon phase, people come together and they bond over shared adversity. They're often optimistic and they may be more receptive to mental health interventions. But as time passes, resources may diminish and support for a disaster wanes as it fades from the news cycle. Health, financial, and other work-related stressors mount, and the reality that things may not return to the previous sense of normal often lead to a sense of disillusionment for people. Anniversary reactions provide a critical opportunity for leaders to support community recovery by acknowledging losses, helping people to make meaning of an event, and then to look hopefully to the future. And it's also important to remember that protracted public health emergencies like COVID-19 often disrupt these phases. The natural coming together may not happen in the same way, and community divisions are often much more pronounced, which may lead people to feel more isolated and disconnected. We can think of stressors like a toxin, such as lead or radon. To assess risk and to intervene effectively, we need to understand aspects of exposure, such as who, when, how much, and the response over time. It's also important to remember that resilience to stressors is not an innate characteristic and it's not a static thing. Resilience evolves over time, and it's often a function of an individual or a community's network of stressors, as well as factors that buffer against those things. In disasters, we think about risk as being the interaction of pre-event factors, event characteristics, and recovery variables, resulting in a cumulative exposure. So in this way, the duration and severity of exposure to various traumatic aspects of a climate-related disaster are an important aspect of risk. And though disasters can look different, they often share aspects of risk. Hurricanes displace people from their homes and neighborhoods, while a pandemic might limit mobility and require people to quarantine. But both can increase feelings of social isolation. A hurricane might flood or damage roads and lead to power outages, whereas a pandemic leads to stay-at-home orders and physical distancing requirements. But both circumstances can serve as barriers to seeking and receiving healthcare. So as we've seen in numerous disasters, including Hurricane Katrina, West Coast wildfires, and even now with COVID-19, certain communities are also disproportionately burdened by disasters. We found that certain communities are consistently identified as being at increased risk for adverse mental health effects during disasters. And special considerations in the preparedness, response, and recovery phase are essential to preserve functioning and protect the health of these communities. It's also important to think broadly when we consider who may be at risk and be cautious about any assumptions that we have. If we look at the COVID-19 pandemic, for instance, frontline healthcare workers have certainly had a wide range of exposures and associated potential risks. But those not involved in direct patient care may experience unique stresses that are related to increased work demands, less organizational and community recognition of the work that they're doing, a reduced sense of meaning in the work that they're left to do, as well as feelings of guilt for not being on the front lines. Population level health surveillance helps us to know where risk is concentrated and how it's changing over time. I'm going to briefly share a few findings from COVID-19 because they are such excellent examples that highlight important aspects of risk that can occur in all kinds of disasters, including climate-related disasters. So we found there was a significant increase in the proportion of ED visits for child abuse and neglect that happened particularly early on in the pandemic. We observed increased rates of drug overdose deaths during the pandemic, with the US exceeding 100,000 drug dose deaths in the 12-month period ending in April of 2021. Social isolation, reduced access to healthcare, and increased feelings of distress may have all played a role in these findings. But these kinds of things are important reminders that our efforts to reduce risk in one area during a disaster may actually increase other types of health risks. As with most disasters, these risks are not distributed equitably. Between 2019 and 2020, the United States experienced the largest reduction in life expectancy in decades. But Black and Hispanic citizens were disproportionately affected, particularly men, when compared to white counterparts. And around the world, individuals with serious and persistent mental illness have consistently been at increased risk of death following infection with COVID-19. We found that even depression itself, which is far more common than our more serious mental illnesses, is associated with worse outcomes when people are infected with COVID. And female physician parents have been disproportionately impacted by increased demands for home and child care during the pandemic. That's been associated with increased rates of depression from baseline when compared to male counterparts. We also want to remember that risk in disasters changes over time. In the US, adherence by the general public to nearly all interventions intended to control the spread of COVID-19 diminished as the pandemic progressed. In numerous countries, increasing opposition to the wearing of face coverings and vaccinations further threatened pandemic recovery efforts. So as we think about different aspects of risk and disasters, we can remember that knowing where risk is concentrated and how it's evolving over time within a group, an organization, or other community helps to more effectively anticipate needs, resources, and interventions during all disasters. And it's also important to look for measures of resilience or even the good things that can emerge from bad situations. So for instance, we could think about one segment of the healthcare workforce or our society more broadly that was been more homebound during the pandemic. For some people in our society, staying at home brought increased risks of using drugs or alcohol or other challenges like family conflict. But for others, it's been an opportunity to spend time with family or develop stronger ties to their community, find ways to enhance their self-care and other things. It's important to understand all sides to behavior that for some bring risk, and for others are protective and may even result in growth. The treating psychological disorders is an important part of caring for mental health after disasters, and is an area with which most people are most familiar. So as I mentioned before, I'm not going to talk about that. The scope and magnitude of disasters, whether it's a hurricane, a tsunami, or a pandemic, requires us to focus more broadly on community level public mental health approaches that enhance wellness and preserve functioning by addressing early responses to trauma before psychological disorders occur. So I'm going to talk about a framework here for early interventions after disasters, and I'll mention a few examples and highlight some of those. So following exposure to trauma and other extremes of stress, we can reduce distress and improve functioning through interventions that foster 5 essential elements. And these include enhancing a sense of safety, calming, self and community efficacy, social connectedness, and hope. And these elements form the basis of what's been called psychological first aid, which is an evidence-based framework for supporting resilience in individuals, communities, and organizations. It's good to remember that any interventions intended to enhance these elements are most effective when they take into consideration the unique cultural and contextual factors within a community. Strong communities are protective during disasters. Our center looked at community efficacy, which is characterized by a belief that one's neighbors will be there to support them when difficult things happen. It's a measure of community strength. And we examined collective efficacy in over 2,000 Florida Department of Health workers following the devastating 2004 hurricane season. And as you would expect, workers who reported higher levels of injury had significantly higher rates of probable post-traumatic stress. However, we also observed 2 things related to collective efficacy. First, respondents who reported living in strong communities had much lower overall rates of probable PTSD. And second, living in stronger communities diminished the role of injury as a risk factor for PTSD. So a better understanding of how to further strengthen communities would really serve to protect health during disasters. The stress continuum is adapted from the US military's combat and operational stress control framework, which can be helpful when thinking about interventions, including which interventions to use and who will deliver them. On the far end are psychological disorders, and these can benefit from treatment by healthcare providers. But much of what people experience on this continuum is not a disorder. For most people, individuals in their communities, such as family, friends, coworkers, and supervisors, play a role in preserving that individual's well-being and functioning. It's also important to consider that many people will never seek medical care to deal with disaster-related distress, but they might talk to a friend or a coworker or someone else within their support system. So community-level interventions that make support more accessible and increase the likelihood that it will be used to by leveraging a wide range of resources. This slide should serve to highlight for you that there are multiple factors to consider for individuals, organizations, and leaders that serve to protect health and maintain functioning. And we can almost think about our stress continuum in the context of COVID-19 or any disaster, and specifically maybe who plays a role in sustaining well-being and functioning for healthcare workers, one segment of those who respond and are impacted by disasters. So I'll conclude my talk today by briefly highlighting 3 interventions to protect public mental health in disasters. When we think about factors influencing our communities, media plays a significant role. Media is an important source of health information, and it shapes public perception as well as subsequent behaviors. Media also transmits fear and distress. Research has found that increasing exposure to disaster-related media is associated with a greater risk of adverse effects, including lower rates of perceived safety, as well as increased rates of insomnia, alcohol use, depression, post-traumatic stress symptoms, and general psychological distress. So given the ubiquity of mobile devices and a 24/7 media cycle, a significant challenge to caring for our communities, but that can help to protect health during disasters, involves finding ways to encourage people to use media wisely It's good to think of communication as a mental health intervention. Dr. Gessel Edelsberg just mentioned that words we choose have power, essentially, and that messaging during disasters has a profound impact on how people perceive risk, their trust in institutions, a willingness to engage in recommended health behaviors, and ultimately the trajectory of community recovery. So messages that are easy to understand, that normalize common responses, and which address the evolving concerns within different communities are important in order to optimize disaster-related health behaviors and to protect community health. Grief is a near universal experience for communities that are impacted by disasters, whether that's grief over a loss of a sense of safety in our homes and communities, certainty about the future, our physical homes and a place of residence, or treasured possessions that are lost, our health and well-being, and even the lives of people around us. In 1985, a plane crashed in Gander, Newfoundland, killing all 248 soldiers and crew members on board in what remains the deadliest peacetime air disaster in military history. The term grief leadership was coined by Dr. Colonel Larry Ingram from the Walter Reed Army Institute of Research to describe a range of leadership behaviors around grief and loss that were associated with improved functioning and recovery within affected communities. So leaders promote healing and recovery within their communities by communicating openly to acknowledge and address issues of grief, facilitate processes that honor losses, and helping people look hopefully to the future. And I'll close by sharing a recent resource from our center that might be helpful as the holidays approach. This fact sheet and many other actionable resources that explain often complex topics in a simple way and provide brief and actionable recommendations on what to do and maybe some things to avoid are all available freely at our website. And I look forward to any discussion.
Thank you, Josh. That was fantastic. And I think getting the point across about that base level is really important, especially as climate change tends to increase that base level over time. Which translates into what the responders have to cope with when something acute happens. But at any rate, we have a few minutes for questions here. And if there are any, please let us know. I haven't seen any in the chat room at this point. I'll start off with a question that I asked a previous group. And one of the things we're aiming for after this conference and the work we'll be doing in the future is how do we improve the preparedness of responders through education and training, especially health responders. And we asked them to identify an area where you think our training and education is most deficient. And I just asked what your opinion would be if we needed to fill out an area in undergraduate and graduate education, what would it be?
I would love to see people far more broadly trained in something like psychological first aid. An understanding of the essential elements and the importance of those. When we think about how often and how many people in our country are trained in basic life support, and how many of those people ever encounter someone in an acute cardiac or cardiopulmonary arrest, the number is small. If we think about the number of people that we will encounter in our life who are exposed to extremes of stress, or ourselves, our friends, our family, our neighbors, or trauma, the number is dramatically higher. So training people in psychological first aid really makes sense. To better understand and equip people at a younger age, get them while they're young. I like your idea. To build a foundation of knowledge in terms of how to support people around us in our own organizations, our communities, our families. And certainly for healthcare personnel, a good foundation for how to interact with patients that are in crisis and their families, which is something that if you do clinical care at all that involves patients, you will encounter people in crisis. So I could see a lot of potential value in building in or baking in something like that to education much more broadly for our society.
And not a question, just an observation on a different perspective. With COVID, we've received, I think, well over 1,000 manuscripts into the journal. And I would say about 50% of the ones we've received over the past couple of months have to do with mental health, anxiety, especially with house staff, et cetera. One of the things that becomes terribly obvious is the poor understanding of the diagnosis of PTSD amongst health professionals. We get so many articles in that say PTSD as if it was a knee-jerk reaction and the only thing that people are going to be affected by after an event. And I don't know how you counter that.
Sure. Well, I think I started out by talking about the issue that PTSD is really an area that has received a considerable amount of focus, and it's a good thing that it has. Our awareness of it as a diagnosis and to be able to identify it, address it, and to begin to develop appropriate treatments for it has been exceptionally important, and it remains important. But I think your question about how do we broaden people's thinking to the issue of other public mental health effects of disasters, as I mentioned, that are often earlier and more pervasive. You might consider special issue on the mental health effects of disasters beyond psychological disorders. How do we increase our understanding of those things? Another important area that I think will really help to advance the field and our ability to respond to disasters as well would involve a better understanding of which of the sort of essential elements would be helpful and when. We have a general understanding, and there's a good evidence base that these are important factors and important elements, but exactly how those look, what actions enhance those for which groups and when, are areas that we really need to understand better, and research that can inform on those would certainly serve to advance the field in a great way.
And last comment on my part, and again, thank you. I think that was a fantastic presentation. We're planning over the course of the year to have a series of webinars which will drill down on the areas that we're presenting in an overview sense here today. And one of those areas will obviously be disaster mental health and its interaction with climate and health. And we would certainly look forward to working with you and your colleagues in terms of, helping to put that together so it meets the kind of endpoints you were discussing.
Happy to do so. Glad to work with you.
Love volunteers. Yes.